Thank you. Assalamu alaikum. Welcome you all to today's presentation. Today we'll discuss about postpartum stroke. Actually, it's a peripartum stroke. I am Dr. Mohammad Rokunujaman, consultant neurologist, Department of Stroke and Intervention Neurology, National Institute of Neuroscience and Hospital. Going to present my topics on postpartum stroke. Before starting our presentation, we will tell a real scenario of a patient. A young lady presented to me with history of LUCS 7 days back, presented with several episodes of convulsion and restlessness, followed by loss of consciousness for last 24 hours, but no history of headache, vomiting, abdominal pain, shortness of breath. On examination, pulse 82 beat per minute, blood pressure 220/140, respiratory rate was 20 per minute, temperature 98, chest and cardiovascular system examinations were normal. Neurological examination reveals GCS was E3, V4, and M4. PP was reactive, but no neck rigidity. An urgent MRI was done, and it shows, this is a FLAIR image showing multiple hyperintensity, especially on the posterior region, and also some hyperintensity in the anterior regions. And this is a DWI restriction, DWI image, diffusion weighted image, and it's showing some auto restriction. That means hyperintensity in also in the DWI sequences. What is the diagnosis? A young lady with recent history of LUCS presented with loss of consciousness with previous history of recurrent convulsion, followed by loss of consciousness. And with this scenario, the MRI was done, and that MRI is showing some hyperintense lesion. It's a very common issue in postpartum period. It is called PRES, posterior reversible encephalopathy syndrome, and the patient was treated appropriately. We will discuss it in our lecture. After treatment, her CT scan was totally normal. This is the before treatment hyperintensity, and this is the after treatment MRI FLAIR image, which is there is completely normal. Patient was clinically completely normal, and radiologically also normal. Now we will move to our main lecture, epidemiology of stroke in women. We all know stroke is the leading cause of death and disability in adults. And worldwide, stroke incidence, prevalence, and mortality are higher in men than in women, especially in developing countries, except some Arab countries like in the Middle East and North African people, where stroke mortality is higher among women. And in women, especially at the time of pregnancy and postpartum period, the stroke is 3 times higher risk than any young adults. The incidence of stroke during pregnancy ranges from 9 to 34 per 100,000 deliveries worldwide. All types of stroke can occur in pregnancy, but among strokes, intercerebral hemorrhage carries the highest mortality and morbidity, and it almost 20% in hospital mortality. Interestingly, the morbidity following a pregnancy-related stroke is lower than a typical stroke patients, and the risk of recurrent stroke in subsequent pregnancy is very low. But stroke-related mortality in case of pregnancy and postpartum period is very high. The mortality is around 20% in hospital mortality. In UK, the incidence rate is same like worldwide, 11 to 26 deliveries per 100,000, and 18 to 15% of all pregnancy stroke patient victims die. If we compare the cesarean section deliveries and vaginal deliveries, stroke prevalence is more among cesarean section deliveries. It is 3 to 12 times higher. A study in UK identified that thromboembolism was the leading cause of maternal death. Thromboembolism is a leading cause of maternal death. We all know strokes are divided mainly into two types: hemorrhagic stroke and ischemic stroke. Both types of strokes can happen in pregnancy and in the postpartum period. Hemorrhagic stroke usually develop from hypertensive disorders of pregnancy. It's a very uh, uh, important issue, hypertensive disorders of pregnancy. We can call it HDP, like preeclampsia, eclampsia, HELP, reversible cerebral vasoconstriction syndrome or RCVS, some arteriovenous malformations, and previous aneurysms. These can be ruptured during the pregnancy and postpartum period, as there is some extra stress and some hemodynamic status changes during pregnancy and postpartum period. So these AVMs and aneurysms can rupture this time. And hypertensive disorders of pregnancy is the most culprit for ICAs in pregnancy and postpartum period. Ischemic stroke most commonly result from cerebral venous sinus thrombosis, or it is called dural venous sinus thrombosis. Preeclampsia and eclampsia can also cause ischemic stroke, and cardiogenic embolisms. Cardiogenic embolisms can also happen in pregnancy and postpartum period, can cause ischemic stroke. If we find out the trimester specific stroke incidence, we can see stroke occurs mainly at third trimester and leastly at the second trimester, and mostly at the postpartum period, then third trimester. Stroke by in antepartum period, hemorrhagic stroke is 13%, ischemic 29%, CVT is 40%, that is cerebral venous sinus thrombosis. But in postpartum case, the hemorrhagic stroke is 60%, and CVT 40%, and ischemic stroke is 45%. We all know ischemic stroke in the general population is 85%, and rest is the hemorrhagic stroke. But in case of postpartum period, the hemorrhagic stroke in the form of ICAs or subarachnoid hemorrhage, it is 60%, and ischemic event in the form of ischemic stroke, infarction, or cerebral venous sinus thrombosis is 45%. There are different types of, these are the examples of our patients of different maternal stroke. The first patient, it is a intercerebral hemorrhage with massive edema in the CT scan. There is a raised ICP causing brain herniation, brain stem herniation, and the underlying cause was searched, and there is no AV malformation or any type of aneurysms, but patient suffered from eclampsia and preeclampsia. So eclampsia and preeclampsia can cause this type of acute intercerebral hemorrhage. This image showing there is a hyperintensity, that means infarction in the posterior artery territory. This was a young patient, and after evaluation, we have found there was a persistent foramen ovale with right to left shunt that causes this type of embolic stroke, and it happens at the postpartum period. These all are my personal experience. This MRI also I previously showed in the first. At first, there is some hyperintense lesions both in the posterior region and also in the frontal regions, and also there's some lacunar infarctions at the same patients. And this is a case of PRESS, that is posterior reversible encephalopathy syndrome, on the background of a pre-eclamptic patients. This is a CT angiogram. This is a angiogram, cerebral angiogram. This showing there is a multiple vasoconstriction, multiple vasospasm with vasoconstriction. This is a reversible cerebral vasoconstriction syndrome. This patient also suffered from eclampsia and developed thunderclap headache. Cerebral angiogram was done and it's showing multiple vasoconstriction. This is RCVS. This all type of stroke can happen in pregnancy and postpartum period. What are the risk factors of stroke? There are some traditional risk factors you all know: increasing age, smoking, obesity, chronic hypertension, dyslipidemia. These all are the traditional risk factors, but in case of postpartum and during pregnancy stroke, the most common risk factor is hypertensive disorders of the pregnancy, sometimes migraine, especially migraine with aura, some infections. It is very much the pregnant women are very much prone to, and postpartum period very prone to infection that can cause ischemic stroke. Hypercoagulable state, we all know pregnancy is a hypercoagulable state, so ischemic event is very much common in pregnancy and postpartum period. Hypertensive disorders of pregnancy, we should have a clear conception. That means it is defined as gestational hypertension, preeclampsia or eclampsia, and chronic hypertension with or without superimposed preeclampsia are associated with a higher risk of all types of strokes during pregnancy and postpartum period. Why there is hypercoagulable state in pregnancy? We all know during pregnancy the procoagulants are increased and anticoagulants are decreased in pregnancy. There is marked increase in fibrinogen and factor 8, factor 7, factor 9, factor 10, factor 12. And fibrinolytic activity is depressed during pregnancy and labor. So pregnancy and postpartum period there is a hypercoagulable state. DVT is a very common issue, 1 to 2% for vaginal delivery and 2 to 10% for cesarean section delivery. It's a very common issue as this period is very hypercoagulable. So any type of long-lasting rest of the limbs can cause DVT. These all are described in previous in the slides. Now, what are the mechanisms of pregnancy-associated stroke? In case of ischemic stroke, the main mechanism is cardioembolic stroke from any valvular heart disease, which can aggravate during pregnancy. Peripartum cardiomyopathy, persistent foramen ovale, dissection, especially extracranial or intracranial arterial dissection, arteritis, or reversible cerebral vasoconstriction, all can cause ischemic stroke in pregnancy and postpartum period. At the same time, intracranial venous sinus thrombosis can occur in postpartum period mainly. And hypertensive disorders of pregnancy, we already described in the previous slides, that can cause both ischemic stroke and hemorrhagic stroke. We all know during pregnancy, there's some immunomodulatory changes. Some immunomodulatory changes during pregnancy, like here, both innate immunity and T-cell immunity, there is changes. And there is increased expressions of T helper 17, which is a highly inflammatory subtypes of regulatory T cells. And this T helper 17 also increases in any infections or any inflammatory conditions, and these can cause ischemic stroke. So these are the basic pathological pathogenesis of stroke in case of pregnancy and postpartum period. Hemorrhagic stroke accounts for 60% of all maternal stroke. And these ICAs or intracerebral hemorrhage can occur either as a result of ruptured small blood vessels in a uncontrolled hypertensive patients, or in the presence of underlying any vascular abnormalities like AVM, cerebral cavernous malformations, or fragile Moyamoya collaterals. Moyamoya disease is a disease of the young patients, and if the pregnant lady suffered from Moyamoya disease from previously, at the time of pregnancy or postpartum period, these Moyamoya collaterals can be ruptured and can cause intracerebral hemorrhage. Subarachnoid hemorrhage can occur because of rupture of the vascular lesions such as intracranial aneurysms or dural arteriovenous fistula as a result of RCVS or venous hemorrhage. It can also occur, it is very common in case of postpartum period and also in during the third trimester of pregnancy. How do we manage a case of stroke in pregnancy? First of all, we should rapidly evaluate the patient. As you all know, time is brain in case of stroke. In pregnant and non-pregnant patients, the symptoms of ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, cerebral venous sinus thrombosis, all are same as non-pregnant patients. So, first of all, we will assess the vital signs, ensuring stabilizations of PROA, breathing, and circulation. We will check blood sugar level promptly and try to keep the blood glucose level 140 to 180 milligram per dl, that is 7.8 to 10 millimole per liter. We will obtain a rapid but accurate history, including time last known well. Time last known well is very important for acute management of ischemic stroke. And at the same time, we will rapidly examine the patient without wasting any times to differentiate or exclude the stroke mimics. We all know there are lots of stroke mimics. There's some functional and there's some structural stroke mimics. There are lots of stroke mimics. It should be excluded from the history and examination. Then we should obtain an urgent brain imaging, either CT or MRI. If we need CT angiogram or MRI angiogram, we should go for that. At the same time, we should replete the volume depletion. Is there any electrolyte imbalance? We should correct it. We should assess swallowing and maintain nutrition, and utmost try to prevent any aspiration. Investigations, CT versus MRI. There are lots of confusion. এখানে অনেকের কনফিউশন থাকে যে আমরা সিটি স্ক্যান একটা প্রেগন্যান্সি করব কি করব না, বাট রিস্ক বেনিফিট দেখে লিখলে অবশ্যই সিটি স্ক্যান আমরা করব, কারণ সিটি স্ক্যান একটা ব্রেন সিটি স্ক্যান করলে আমাদের রেডিয়েশন এক্সপোজার চান্স থাকে 50 millireadians. 50 millireadians. This is very negligible radiation. For fetal anomalies or intellectual disability, 5,000 milliradians is required. But in case of CT scan of brain, radiation exposure is 50 milliradians, which is very negligible and it is not toxic to the fetus. So we should go for CT scan if there is no availability of MRI, or MRI time consuming, so we should not waste our time for MRI. Better we should go for CT scan and non-contrast CT scan. Question is, will use contrast agent or not? Iodine and gadolinium based contrast agents should be avoided in pregnancy if possible. If possible, we should avoid contrast agent, but we can go for non-contrast CT scan. আমরা যদি পেশেন্টের রিস্ক বেনিফিট দেখে অবশ্যই আমরা non-contrast CT scan আমরা করব. At the same time, we will go for cardiac monitoring and echocardiography. Echocardiography তে আমরা একটা বাবল contrast study with agitated saline আমরা করব। Is there any evidence of persistence from an ovule with right to left shunt দেখার জন্য? We will go for some laboratory investigation promptly, like complete blood count, metabolic profile, toxicology screening, and lipid profile. At the same time, some additional investigation may be needed, especially in young patients with cryptogenic stroke, no causes found. We can go for hypercoagulability testing. In a young patient, no causes identified, we should go for hypercoagulability testing like antithrombin 3, prothrombin G202110OA, factor 5 laden, protein S deficiency, protein C deficiency. It can be done at any time. These are the molecular testing, but some non-molecular laboratory testing should be delayed until 3 months or more following delivery, like activated protein C resistant ratio, functional assay for protein C, free protein S antigen assay, antithrombin heparin cofactor assay. These are the non-molecular tests. There's some false positive or negative result can be found during pregnancy. So we should delay at least 3 months after delivery if we want to do these investigations. And now the management. Acute reperfusion therapy is the mainstay of ischemic stroke, both in pregnant and non-pregnant cases. And IV thrombolysis and endovascular mechanical thrombectomy are the mainstay of treatment in ischemic stroke. The immediate goal of reperfusion therapy is to restore the blood flow to the regions of the brain that is called penumbra, that is are ischemic but not actually infarcted. So our goal of treatment of reperfusion should be restorations of the blood flow to the ischemic penumbra but not the infarcted area. And IV antiplatelet is now available in our country, and it is given in our hospital, and it is named as Actiles. There are lots of inclusion and exclusion criteria, but the important inclusion criteria is the patient should be present less than 4.5 hours. And antiplatelet pregnancy is considered as a relative exclusion for use of TPA. Antiplatelet is a high molecules and it does not cross the placental barrier. There is no teratogenicity, no tumorigenicity, no mutagenicity. So we can use antiplatelet in pregnancy without any hesitations, except there's some risks. The chief risk to the mother is a symptomatic intracranial bleeding, which is also occurring in other cases, but in pregnancy, as there is the patient, there is more chance of bleeding. So the bleeding, symptomatic intracranial bleeding and bleeding on the other sides of the body is very much common if we use antiplatelet in pregnancy, but we should use it. And till now, no risk was found to the fetus with antiplatelet. So we should give antiplatelet to any pregnant or postpartum period if patient comes within 4.5 hours. And another is the mechanical thrombectomy. It is done in selected patients with acute ischemic stroke caused by large vessel occlusion in the proximal anterior circulation, and it can be treated ideally within 6 hours, but it can be extended up in some special cases up to 24 hours. And endovascular treatment like mechanical thrombectomy is preferred over antiplatelet in pregnancy and postpartum period, as there is least chance of intracranial hemorrhage or other bleeding site in case of mechanical thrombectomy. The efficacy and safety of reperfusion therapy for acute ischemic stroke in pregnancy are not firmly established because pregnant women are excluded from the randomized control trial. But there's some data, observational data, that suggests these therapies are very much safe and effective. On report, evaluating stroke registry data found that the use of acute reperfusion therapy in pregnant or postpartum women was associated with outcomes that are similar to non-pregnant women. So, if there is options of IV thrombolysis like with antiplatelet or mechanical thrombectomy, we should go for that though the patient is pregnant or patient is in postpartum period. Management of hypertension during stroke. In ischemic stroke, if patient eligible for acute reperfusion therapy, we should keep BP less than 185 by 110. Less than 185 by 110. And it should be maintained IV labetalol or nicardipine or clopidogrel. If patient is not eligible for IV acute reperfusion therapy, the BP should be high, should be maintained high, more than 220 by more than 120 diastolic to save the penumbra, ischemic penumbra. But if patient suffering from active coronary heart disease, heart failure, aortic dissection, hypertensive encephalopathy, preeclampsia or eclampsia, we should not wait this high BP. But in other cases, we can stop or hold the antihypertensive drug up to 220 by 120. When treatment is indicated, we should lower BP very cautiously. 15% during first 24 hours after stroke onset is suggested. If patient was previously hypertensive, we can restart the antihypertensive medications if BP more than 140 by 90, who are stable neurologically and not contraindicated, but it should be started 24 to 48 hours later of the stroke event. For intracranial or extracranial stenotic patients, we can restart the antihypertensive after 1 to 2 weeks. We should try to maintain high BP in case of ischemic stroke, কারণ আমরা এখানে ইসকেমিক পেনাম্বরাকে যদি আমরা সেভ করতে চাই, বিপিটাকে আমরা হাই রাখতে পারলে ইসকেমিক পেনাম্বরাটা সেভ হবে। এই কারণে এবং দেখা যায় যে কিছু কিছু ক্ষেত্রে কিছু আমরা বলি যে পেশেন্টের স্ট্রোকের কারণে তার বিপিটা কিছুটা ট্রানজিয়েন্টলি বাড়তে পারে, আবার এটা 2 থেকে 3 দিন পর থেকে বা 1 সপ্তাহ পর থেকে বিপিটা কিন্তু আবার নরমাল চলে আসে। এই কারণে আমরা চেষ্টা করব বিপিটা হাই রাখার জন্য সব সময়ের জন্য। Acute antiplatelet therapy. Early aspirin therapy is recommended for patients with acute ischemic stroke who are not receiving full dose of anticoagulation. Aspirin should be given within 48 hours of onset of stroke as early as possible. এবং যদি আমরা IV thrombolysis ইউজ করে থাকি তাহলে সেক্ষেত্রে first 24 hours we should hold the aspirin. Clopidogrel or any other regimen of dual antiplatelet therapy to treat ischemic stroke or TIA during pregnancy is not recommended. We should not use clopidogrel or any dual antiplatelet therapy initially. In case of other cases, যদি পেশেন্টের ischemic stroke but minor stroke থাকে, তার NIHS স্কোর যদি কম থাকে, সেক্ষেত্রে আমরা ইনিশিয়ালি ডাবল অ্যান্টিপ্লেটেড ইউজ করে থাকি প্রথম 21 দিন অথবা 3 মাস, এরপর আমরা সিঙ্গেল অ্যান্টিপ্লেটেড কন্টিনিউ করি। বাট ইন কেস অফ প্রেগনেন্সি অর পোস্টপার্টাম পিরিয়ড আমরা ক্লোপিডোগ্রেল ইউজ করতে পারবো না বা ডুয়াল অ্যান্টিপ্লেটেড ইউজ করতে পারবো না। উই শুড ইউজ অ্যাসপ্রিন at low dose 75 to 81 milligram dose. Aspirin is category D, but at low dose it is safe. Low dose means 75 to 81 milligram, it is safe. Clopidogrel is category B, dipyridamole is category B, but when it combines with aspirin it's category D. Heparin and heparinoids category C. Warfarin is category X. It should not be used in pregnancy or pregnancy. Treatment of acute thromboembolism in pregnancy. Here we should use low molecular weight heparin instead of unfractionated heparin or vitamin K antagonist like warfarin. And this low molecular weight heparin should be continued for more than 6 weeks postpartum. Minimum duration 3 months. Discontinuations of low molecular weight heparin or unfractionated heparin more than equal to 24 hours prior to inductions of labor or cesarean section. So যদি আমাদের ইলেকটিভ সিজারিয়ান সেকশন অথবা পেশেন্ট লেবারে যায় তার ঠিক 24 ঘন্টা আগে অবশ্যই আমাদেরকে লো মলিকুলার হেপারিন অথবা আনফ্র্যাকশন হেপারিন যদি আমরা আগে ইউজ করতে থাকি এটা আমরা হোল্ড রাখবো। But in postpartum period, aspirin, clopidogrel, and the combinations of aspirin, extended release dipyridamole all are acceptable for preventing recurrent non-cardiomyopathic ischemic stroke after pregnancy. And aspirin should be given up to 81 milligram, and it is safe in both pregnancy and in postpartum period. There are some secondary preventative measures in stroke outside of pregnancy. Postpartum stroke prevention management for women with history of stroke. First of all, we should educate all the women on signs and symptoms of stroke and what to do. We all know the first face, arm, speech, and time, and call 911, which is not available in our country because the first 6 weeks of postpartum period is the highest risk period. And here, neurologists, vascular neurologists, obstetrician, and primary care specialists, primary care doctors are very much play a vital role. Women with diabetes, hypertension, preeclampsia, or other high risk conditions may need close postpartum monitoring. Review long-term stroke prevention plan and breastfeeding. Prior stroke is not a contraindication to breastfeeding, and women with a prior stroke may need assistance for these tasks and other tasks to care for the baby. Stroke prevention medication should be evaluated for compatibility with breastfeeding. If high risk of thromboembolism in the first 6 weeks postpartum, anticoagulation with low molecular heparin or warfarin is safe option. These are the secondary preventive measures in case of postpartum period. Now we go for cerebral venous sinus thrombosis. CVT can cause symptoms of focal dysfunction that mimics ischemic stroke. We all know, as pregnancy period is the hypercoagulable state, CVT is more common at this time than other times, and postpartum period has the highest risk of CVT. One study demonstrated that the risk of intracranial venous sinus thrombosis was 11.66 cases per 100,000 deliveries. It's a very high. How a CVT patient in pregnancy present? The presentation is same like that of a non-pregnant patient, like headache, vomiting, focal or generalized seizure, confusion, blurring of vision, focal neurological deficits, and or altered level of consciousness. For diagnosis of CVT, urgent neuroimaging in the form of CT contrast, MR venogram, CT venogram is done. This patient presented with headache and blurring of vision. CT scan was done. This showing this hyperdense dural sign, hyperdense vein sign or dot sign or clot sign. And this is the CT contrast of that patient showing this empty delta sign. And this is the MRV of that patient showing this filling defect in the suprasagittal sinuses. And the mainstay of treatment of CVT, irrespective of pregnancy or non-pregnancy, is anticoagulation. If patient presented with hemorrhagic infarction or not, anticoagulation is the mainstay of treatment. অনেক সময় আমরা দেখি যে অনেক ভেনাস সাইনাস থ্রোম্বোসিস গুলো একটা ব্লিডিং হিমোরেজিক ট্রান্সফরমেশনে আমাদের কাছে প্রেজেন্ট করে, তখন আমরা কনফিউশনে থাকি যে পেশেন্ট গুলোকে আমরা অ্যান্টিকোয়াগুলেশন দিব কি দিব না। বাট ইরেসপেক্টিভ অফ আইদার হিমোরেজিক ট্রান্সফরমেশন অর নট, আমরা সব পেশেন্টকে অ্যান্টিকোয়াগুলেশন করব। ফর উইমেন উইথ সিভিটি ডিউরিং প্রেগনেন্সি, guidelines from the AHA-ASA conclude that low molecular heparin in full anticoagulant dose, that means 1 milligram per kg body weight in 2 divided dose, should be continued throughout the pregnancy. full anticoagulant throughout the pregnancy. And low molecular weight heparin or vitamin K antagonist with a target iron of 2 to 3 should be continued for at least 6 weeks postpartum for a total minimum of 6 months, at least 6 months. If there is underlying any thrombophilic disorder like protein C deficiency, proteinase deficiency, then this warfarin should be continued lifelong or indefinite period. Cerebral hemorrhage. Women at risk of ICS in pregnancy are those with eclampsia, vasculitis, aneurysms, or vascular malformations. And the high blood pressure is the most important risk factors for intracranial hemorrhage in pregnancy. We all know subarachnoid hemorrhage or ICS during pregnancy or postpartum period is caused by hypertensive disorders of pregnancy like preeclampsia, eclampsia, and HELLP syndrome, reversible cerebral vasoconstriction syndrome, and vascular malformation. And we should treat the underlying cause in associated with some general management. Preeclampsia and eclampsia retrospective data suggests that severe preeclampsia and eclampsia or HELLP is the cause of 14 to 55% of all hemorrhagic stroke in pregnancy. And the management goals are stabilization of the mother, prevent recurrent convulsions, treat severe hypertension, especially with IV antihypertensives to reduce or prevent cerebral edema and hemorrhage, and as early as possible initiate delivery of the fetus. If there is vascular malformation like intracerebral aneurysms or AVM, it can be managed by surgery, that is clipping, or endovascular coiling embolization. This can be done in pregnancy and postpartum period with some caution. Like in case of endovascular coiling, we can use the abdominal shield to protect from the X-ray, but there is no absolute contraindications. If needed, we can go for endovascular coiling at the time of pregnancy or in the postpartum period. These are the acute spontaneous ICS patient general management. We all know. We will not discuss it in details. Posterior reversible encephalopathy syndrome. The symptoms of severe preeclampsia, eclampsia, and HELLP are the most common cause of ischemic and hemorrhagic stroke in pregnancy, but at the same time, it is the most common cause of PRES, posterior reversible encephalopathy syndrome, which is also known as reversible posterior leukoencephalopathy syndrome. Patient usually presented with headache, blurring of vision, scotomata, cortical blindness, generalized tonic-clonic seizure, and some untreated patient may progress to coma. We already discussed the neuroimaging showing vasogenic edema, especially in the subcortical white matter, predominantly in the parietal and occipital lobes. This is the case of PRES with pre-existing eclamptic patients. There is hyperintensity in the posterior occipital regions and also parietal regions. Management. The goal of management of severe preeclampsia and eclampsia and HELLP are to stabilize the mother, prevent further convulsions, treat severe hypertension, especially with IV antihypertensive, either labetalol or hydralazine, and promptly to reduce the reductions of cerebral edema and hemorrhage, and as early as possible, prompt delivery. Magnesium sulfate can be used for seizure prophylaxis, and sometimes platelet transfusion is needed in HELLP syndrome if there is significant maternal bleeding, and if platelet count is less than 20,000, we should transfuse platelet in case of HELLP syndrome. This is the algorithm of using antihypertensive in eclampsia and preeclampsia. Where systolic BP is more than or equal to 160 and diastolic more than or equal to 110, we should use antihypertensive. If there is possibility of IV access, we should administer labetalol 20 mg IV over 2 minutes. We'll wait for 2 10 minutes. If there is no response, we can double the dose, that is 40 milligram IV. We can wait another 20 minutes. No response, we can double the dose, that is 80 milligram. We can wait another 30 minutes. No response, we can use another 80 milligram. No response, after 40 minutes, we can administer another 80 milligram. The total dose is 300 milligram per 24 hours. Instead of intermittent bolus, we can give continuous infusion of 1 to 2 milligram per minute. It can be used. If patient is still severe hypertensive, we should administer hydralazine in repeated bolus dose. If it is not responsive with hydralazine, we should go for nicardipine. So these are the algorithm to use antihypertensive in case of preeclampsia and eclampsia. And after stabilization, we should maintain the BP. After stabilization, we should maintain the BP with some oral medications. And we should keep in mind that during management of eclampsia or preeclampsia, mean arterial pressure should not be reduced by more than 25% over 2 hours. And systolic BP should not be reduced less than 130, and diastolic BP should not reduce less than 80. Our target is 130 to 150 systolic, and diastolic is 80 to 100. During treatment, heart rate and blood pressure should be monitored very closely. If delivery will not occur for days to weeks, we should maintain the BP with some maintenance therapy, if required, with oral antihypertensive drugs. For pregnant patients with non-severe chronic hypertension, that is blood pressure more than equal to 140, diastolic more than equal to 90, or both, on at least 2 occasions, at least 4 hours apart before 20 weeks of gestation, antihypertensive treatment is recommended to keep the BP less than 140/90. Here, labetalol or extended release nifedipine is preferable. Prognosis. Most case series and case reports suggest that reversible posterior encephalopathy syndrome or leukoencephalopathy syndrome is usually benign. And most of the cases, this patient fully reverse within period of days to weeks after removal of the inciting factors and control of blood pressure. But radiological improvement needs some time. Death and permanent neurological disability sometimes occurred as a consequence of this. And death usually results from progressive cerebral edema or from ICAs or as a complications of the underlying condition. Postpartum cerebral angiopathy. Postpartum cerebral angiopathy is a rare form of reversible cerebral vasoconstriction syndrome, which appears from 1 day to 6 weeks of postpartum period. Here, affected cerebral vessels shows signs of inflammations on histological investigations. These inflammatory changes seem to be mainly chronic and secondary to prolonged vasoconstriction, suggesting functional vasoconstriction as the primary pathological process. Patient usually presented to us with multiple thunderclap headache that recur nearly every day over 1 to 4 weeks, are almost pathognomic of RCVS in case of pregnancy or postpartum period. It is also known as migrainous vasospasm or migraine anxieties, Call Fleming syndrome, thunderclap headache associated with vasospasm, drug-induced cerebral arteritis, postpartum cerebral angiopathy, benign angiopathy of the CNS, and central nervous system pseudovasculitis. If we go for blood testing, we can find raised ESR and leukocyte count. CT and MRI are usually normal, but later some cerebral ischemia can be seen, sometimes hemorrhage or edema can be seen. And if we go for lumbar punctures, the CSF is usually normal. Cerebral angiography usually reveals areas of stenosis and dilatations in multiple intracranial vessels. This is a patient in the upper panel MRI performed on admission showed flare hyperintensity and diffusion restrictions in the right parietal lobe and also in the splenium of the corpus callosum. Lower panel done on hospital day 3 when the patient deteriorated, showing worsening of the bilateral lesions involving on both sides, and a CT angiogram was done, which showing there on the left side there is MC is constricted, on the right side the AC is constricted, the basilar artery also constricted, and the vertebral artery also constricted, and it is the RCVS. And after few days, the CT angiogram, MR angiogram was done, and the vessels are now completely normal. So it's a benign condition, and it is a reversible condition. Usually, supportive treatment is required for RCVS. There is no established specific therapy for that. We should control her BP. Sometimes ICU monitoring is required. Patient usually complaining of thunderclap headache, so pain of RCVS sometimes need opioids, sometimes NSAIDs. If patient present with seizure, acute seizure treatment is required, just supportive treatment, and we should avoid empiric glucocorticoids. আমরা সাধারণত এই ধরনের পেশেন্ট আসলে যদি সাসপেক্ট করি যে আরসিভিএস, আমরা সবাই এমপিরিক্যালি গ্লুকোকর্টিকয়েড দিয়ে থাকি যে পেশেন্টের প্রাইমারি সিনাস ভাস্কুলাইটিস আছে কিনা, কারণ অনেক সময় প্রাইমারি সিনাস ভাস্কুলাইটিসের ফিচার গুলো আরসিভিএস এর মতোই হয়। সেক্ষেত্রে আমরা অনেক সময় আরসিভিএস টাকে যদি আমরা কনফার্ম না করতে পারি, সেক্ষেত্রে আমরা এমপিরিক্যালি স্টেরয়েড আমরা দিতে পারি, বাট মেইন ম্যানেজমেন্ট ইজ সাপোর্টিভ ম্যানেজমেন্ট। This is the last section, the hypercoagulable state. We all know pregnancy is a hypercoagulable state, and if a patient of antiphospholipid antibody syndrome presented in pregnancy, how will you manage? Antiphospholipid antibody with prior arterial or venous thrombosis, with or without antiphospholipid defining pregnancy morbidity. Then in antepartum period, therapeutic dose of low molecular heparin and low dose aspirin should be administered. In postpartum period, we can use warfarin for indefinite period of time. If APS, that is antiphospholipid antibody syndrome, based on laboratory criteria for APL and APS defining pregnancy morbidity of more than 1 fetal loss, more than 10 weeks of gestation, or more than 3 unexplained consecutive spontaneous pregnancy loss, less than 10 weeks of gestation, and no history of arterial or venous thrombosis. যদি কোনো ধরনের previous arterial or venous thrombosis না থাকে, then we can consider prophylactic dose of low molecular heparin, that means 40 milligram enoxaparin once daily, and a low dose aspirin. In postpartum period, prophylactic low molecular heparin and low dose aspirin for 6 weeks, regardless of route of delivery, either cesarean sections or vaginal delivery. We can use it for 6 weeks. Antiphospholipid antibody syndrome, based on laboratory criteria and APS defining pregnancy morbidity of more than 1 preterm deliveries of a morphologically normal infant before 34 weeks of gestation due to severe preeclampsia, eclampsia, or other findings consistent with placental insufficiency and no history of arterial or venous thrombosis, then most of the cases we can use low dose aspirin, that means 75 to 81 milligram aspirin in antepartum period. In postpartum period, if patient with history of vaginal delivery, we can go for intermittent pneumatic compression and low dose aspirin while in the hospital, and graduated compression stockings and low dose aspirin for 6 weeks. If patient history of cesarean delivery, we can go for prophylactic dose of low molecular heparin and low dose aspirin for 6 weeks. If laboratory criteria for APS but no clinical criteria for APS, that is no history of venous or arterial thrombosis and no history of APS defining obstetric morbidity, we can give low dose aspirin in antepartum period. If vaginal delivery in postpartum period, we can go for intermittent pneumatic compression and low dose aspirin while in the hospital, and graduated compression stockings and low dose aspirin while out of the hospital for 6 weeks. In case of cesarean section delivery, prophylactic dose of low molecular heparin and low dose aspirin is required for 6 weeks. That's all our presentation. And the take home message is pregnant women and women at postpartum period are at increased risks for stroke secondary to some physiological changes of pregnancy and related complications. The workup for stroke is same in pregnant population as in non-pregnant, including imaging studies. এখানে আমাদের কিছু কনফিউশন থাকে আমরা সিটি করব কি করব না, but we can go for CT. The same treatment modalities may be considered, paying special attention to gestational age of the fetus and risks of bleeding. And all the medications are safe to use during breastfeeding. That's all. Thank you.